Today I'll discuss the physical exam part of my 3 parts of my evaluation for someone with knee complaints. So the first part is the verbal history, where I'm asking very specific questions, getting insight into what I think the diagnosis is. And the physical exam is the same thing. I'm taking specific metrics to help me figure out the diagnosis. So if someone has knee complaints, range of motion is going to be a large part of the physical exam. I'm going to look at knee flexion, range of motion, not only, of course, quantity, but also quality. For example, it really matters to me if I take the person into passive knee flexion when the person is on her back and it hurts during the range of motion, but it doesn't hurt at the end range, or vice versa, or it hurts all the way from 90 degrees to end range. So the quality is really ascertaining if there is pain or discomfort or any number of symptoms during that range of motion. And then we're looking at quantity. Is there full knee flexion range of motion? We can compare it to the other side. Of course, we also compare it to norms. I typically just do this passively in the interest of time, but I can also have the patient do it actively. And more often than not, I'm doing it in supine, but knee flexion in a squat, which we could say is a squat, is also testing loaded knee flexion range of motion. So knee extension range of motion is obviously another central point. I'm looking at that in supine. I am holding on the distal femur and then pulling up under that patient's heel to see how much extension is there, and of course the quality. For most patients with knee complaints, I am also doing the same thing for hip range of motion bilaterally. I'm doing knee range of motion bilaterally. We need to know what we're comparing it to. And for the hip, I'm looking at flexion, ER, IR, sometimes abduction, sometimes extension. Again, in this concrete amount of time, I have to choose the baselines that are the most important for me to gather. The list is not infinite, but the list is long. So based on the verbal history, I'm choosing which parts of the physical exam are most important. For most people, I'm going to be looking at hip range of motion, quantity and quality bilaterally. For most people, I will look at lumbar range of motion, inflection, extension, right side glide and left side glide, quantity and quality. For fewer people, I will look at knee rotation range of motion. I will look at ankle range of motion. So the range of motion is primarily those 3 sites, sometimes down to the foot ankle, maybe sometimes up into the thoracic spine, but I'm hardly ever doing that in the evaluation on day 1. So outside of range of motion, I look at strength. For most people, not all, but I can test knee extension strength. So the quads, I can look at knee flexion strength, primarily the hamstrings. I typically do it seated on the edge of the bed, but there are various ways to do it. I'm typically going to be testing hip flexion strength, quality, and quantity, and hip abduction. I find those 2 to be more relevant than the other ones, but I may also look at other planes of motion in the hip in terms of strength. I may look, depending on if I think there's more of a possibility of the knee complaint coming from somewhere higher up, like the hip or the lumbar spine, I may look at strength around the ankle complex. I don't test any strength in the trunk in having to do with the lumbar spine or the thoracic spine or hip flexion. The lumbar range of motion that I'm taking the range of motion of the lumbar spine is usually where the lumbar baselines are coming from in terms of, not in strength, but mostly in range of motion. So that's range of motion, that's strength. Nerve tension is another kind of top 3 baseline I'll take for orthopedic complaints. Nerve tension, I'll do a quick passive straight leg raise test for most of these patients with knee complaints. I may look at a femoral nerve tension test in prone, which is just bringing the heel to the patient's buttocks or as far as it goes, noting if there are any complaints, and of course, if there are complaints, where the complaints are. So outside those 3 big ones, I typically, or always, I'm trying to find a functional baseline. And I preface that by asking the patient, is there something we could do here in the office that would recreate your complaint or something you have a problem with? It could be walking in the hallway. It could be sitting on the knee, so maybe kneeling. Maybe it's rolling over in bed. Maybe it's doing a squat. Maybe it's doing a lunge. Maybe it's doing a plank. Any number of things that recreates the reason that patient is in the office is something I would love to recreate so that we, in part 3, when we do the cause-effect analysis of testing, repeated movement testing being the primary test, we want to have something that we can say, oh, is walking in the hall worse, better, about the same? Is a squat worse, better, about the same, right? Can you get deeper before the pain comes on? Is the pain less intense? Is the pain more local to the knee versus diffuse around the knee? There are so many different parameters we're looking for. And just like I said about part 2, in the interest of time, it's my job as a clinician to choose which information is the most potent, because I do a long evaluation, but even so, I could benefit from an even longer evaluation in most cases. But what I don't test on day 1 that I later find to be of value, I will test on subsequent visits. So it's not that you can't ever do it if you don't do it on day 1. You just do the things on day 1 that you really need to get the ball rolling in terms of diagnostic testing and or treatment. Sometimes you can know what the treatment is on day 1, although I argue that's few and far between. I argue that you need to do consistent, thorough testing of movements and see what effects they have on the body before you can arrive at a very pinpoint specific treatment that we know is the treatment without question. So I will look at a functional baseline. Outside of those three in a functional baseline, sometimes those patients don't have a functional baseline, like, oh, my knee hasn't hurt in 2 days. I will try to ask them, like, are you sure? Like, how about pigeon pose? Or how about standing on one foot and hopping? I'll try to find something, or stepping up onto a high chair or a box. There are other baselines I will take in physical exams, such as how much balance do you have standing on one leg, or how much control do you have descending on a lunge? And those things sometimes are picked up on in the functional baseline portion, but we can look at things like balance or motor control and maybe a few others, but that's not the meat and potatoes of my physical exam. I'm really focusing on range of motion, quantity and quality bilaterally, and at the relevant spine. The lumbar spine is relevant because the nerves that exit the lumbar spine are what control the muscles that surround the knee, and the nerves that come from the lumbar spine, some of them can specifically, deliberately send pain to the knee, especially L3. So it's a very important part of the baseline taking for me in nearly all patients with knee complaints. But after the physical exam, after I've collected all those data points, which is probably 20 to 30 or 40 different data points, if you think of hip internal rotation on the left, quantity and quality, and hip internal rotation on the right, quantity and quality, well, that's 4 right there. So we have a lot of different data points, and taking all those data points in conjunction with the information that I've gathered from the specific verbal history is cumulative. Those points, those pieces of information dictate what to test in the testing. In the clinical testing, do I need repeated movement testing? Do I need ligamentous stability testing? Do I need to do better screen for a fracture? Do I need testing outside this office, which is very rare, but sometimes we do need imaging. So most times the conclusion I gather or make is that repeated movement testing of a joint, either the knee, the low back, the hip, is the most valuable testing, because I want to make sure that the problem isn't a mechanical joint derangement, because those are the easier ones to fix. Mechanical joint derangements can be fixed in days to weeks with the correct movement, which we may take longer to find than people would like, but often we find the movement very quickly that's effective. If it's not a mechanical joint derangement, if we're thinking it's more structural or degenerative or some other kind of more aggressive process like a tumor, then that treatment is obviously very different, but also takes longer. So we want to make sure it's not the easier solution first. And it's not just that mechanical joint derangements are easier with regard to treatment versus most other diagnoses. It's also that that's what I find is the most prevalent. So it's kind of like if someone has a headache, you want to rule out first that it's a cold or dehydration or any causes that are relatively prevalent before you're jumping to your head pain is due to cancer in your brain. You want to rule out prevalence things first. If the information you gather in the verbal history and the physical exam start to make you think, I think this joint is just not mechanically moving well, and it's because the back is not mechanically moving well, or the hip or the knee itself, you want to make sure that's not the case before you go forward. But at the end of the day, the physical exam for a knee complaint is, I think, in my book, more expansive, especially being considering that I'm really going to look at hip range of motion and possible, hip strength. But I'm really going to look at the lumbar spine and see what I can find there, which may inform the testing. But I think if you exclude the lumbar spine, the low back, I think you're going to be missing a large proportion of somewhat easy fixes, because I find that so many people have knee complaints when the reason is that their back is not moving well. And once you get their low back moving well with some simple movements, the knee complaints will go away.